Okay, hopefully this is the last video if I can do this in 15 minutes. The last part is possibly the most important part of this lecture, and it's these assessments of fetal well-being. It's important, I think, because you're asked a lot of questions and they can be quite confusing sometimes. So I'll try to be very clear on what we're looking for and what we see as a normal or abnormal test. So the first one is pretty easy to understand. It's called kick counts, and we teach this to every patient because, especially later on in pregnancy, we want them to recognize the movements of their baby. If the fetus stops moving for an extended period of time, that is a warning sign, a red flag, when we want to know about it, and we want her to be aware of when to seek providers' help. So what we do is we teach a mom to either lay semi-Fowlers or on her side, and she's going to put her hands on her belly just like you see here, and she's going to feel to see if she can feel the movement of her baby. And we want her to record 10 counts within 2 hours. And if she records 10 counts in 2 hours, then baby's fine. If she doesn't feel 10 movements within 2 hours, we're going to have her do it again. And the baby could be sleeping for part of the time, so if she doesn't feel the baby at first, drink some orange juice, move around, do something to wake that baby up. If she doesn't feel 10 consecutive kicks or movements in the next 2 hours, so a total of 4 hours now, then we want her to come in and be triaged and see if there might be some sort of problem that we need to address. The next one is kind of familiar to everyone, and that's the ultrasound. And we get a lot of things out of ultrasounds. And the great thing is that we don't think there are any known risks, but we can see lots of things that we can diagnose early and we are aware of before the delivery. We can even diagnose Down syndrome with an ultrasound. It's not always the case, but a lot of times you can see for this nuchal bump right here, and that's a sign of Down syndrome. We can also look to see, we can measure the femur to find out gestational age, if there's any intrauterine growth restriction, and then we look at the amniotic fluid volume because we know too much fluid or too little fluid is a risk factor, is a red flag for babies. We can either do it abdominally with a lubricated probe, or we can do it transvaginally if we need to get to see the cervix right here. You can see and see if the amniotic sac, how the amniotic sac's doing. So, like I mentioned, you can see the length of the cervix, any premature dilation leading to incompetent cervix. So an incompetent cervix is a cervix that dilates and effaces before a woman is able to go into labor safely. So within that first or second trimester, she will just keep having loss after loss. And if that happens, we have to do something to stop that cervix from opening up completely and resulting in a fetal loss. But we want to teach the moms to, here's the bladder, fill the bladder, so we can get a better image of that fetus during the ultrasound. Along with the ultrasound, this is the same thing, it's still ultrasound. We want to do, it's non-invasive, but we can look at fetal and maternal blood supply and see how well it's doing. Like I said, any intrauterine growth restrictions, if there's any umbilical or placenta problems, that we can diagnose it by just looking at blood flow with that ultrasound. Okay, the next one is a non-stress test. And you will hear about this a lot. Anytime a patient comes in contracting or that there's worries in the clinic, they will send them in and we'll triage them and we'll do a non-stress test. So what we do is we place the client right here in the semi-Fowlers or sideline, usually looks like this, or in an upright bed. And it's going to evaluate that fetal nervous system and also the fetal perfusion to see if there's any acrocyanosis or hypoxia going on. We do it during that third trimester, and women who have high-risk pregnancies will come in every week to the clinic and have it done. We're going to evaluate the fetus's heart rate to its own movement. So when you and I move, our heart rate should accelerate, and we want that to see that same thing happening with the fetus. So right here you see fetal movement, and you see an acceleration, nice acceleration here. Fetal movement, nice acceleration. Fetal movement, nice acceleration. These are what we want to see, and that is what we're looking for to see a normal non-stress test. So we hook mom up to a Doppler transducer. Right here you can see the monitor right here on that upper fetal back. And then we put on also the TOCO, which is right on that or fundus of the uterus to measure uterine contractions, see if she's contracting at all. And then we're going to take a baseline of that fetal heart rate to see where that fetal heart rate lies. We're going to do that for at least 20 minutes. Then every time we're going to give that mom a clicker or a button, and every time she feels fetal movement, she's going to click that button. And that's what we're going to compare to the fetal heart rate. So if there's a button pushed, you saw that line on the previous screen. If she pushes a button, then we should see an acceleration. And not necessarily every time, but we want to make sure we see enough to make sure that it is a normal non-stress test. So if the baby's sleeping, we can give orange juice or vibroacoustic stimulation, which is just you use a tool to make a sound and wake that baby up. And then the results are taken over 20 minutes also. So baseline for 20 minutes, results over 20 minutes. And then we're just going to evaluate. A reactive or a normal non-stress test shows moderate variability. Remember, we want to see the heart rate going up and down and not just kind of staying in one little line. We want to see these accelerations that I showed you on the last screen. And this means we want to see an increase of at least 15 beats per minute for at least 15 seconds. And that is what is classified as a good acceleration. And we only need to see it 2 or more times within 20 minutes. So not even a lot, but we want to make sure it happens 2 or more times. If we don't see that, then the test will be non-reactive or abnormal. We don't see any accelerations. We probably see minimal variability. And we'll do further testing, or we'll just induce that mom and get that baby out because we feel like that's the safest thing for the baby. So one of the tests we can do is a biophysical profile, and it's using an ultrasound you can see right here, and we're just going to measure 5 different things that we can look for in the monitor, in the ultrasound. So we're going to look for the fetal heart rate to see if that's within normal range, and each of these get a score of a 0 or a 2. So a 0 if it's not normal, a 2 if it's normal. Same with fetal breathing movements. Fetuses do not breathe, but they should have breathing movements at the rise and fall of the chest, and that is normal growth and development for a fetus. If that is not happening, then something might be wrong with the CNS, central nervous system. We want to see gross body movement. So we want to see that baby moving around and not just kind of lying there flaccid within the uterus. And we want to make sure that the fetus is nice and nice flexed position. So a baby that is not flexed and just kind of lying there is a sick baby. So we want to make sure it's nice and flexed. And then we want to look to see if there's an adequate amount and not too much of the amniotic fluid volume. And then we total these up, either a 0 or 2. And then if we get an 8 to 10, then we know that that fetus is normal, or it's a normal biophysical profile. Anything 4 to 6, we suspect there might be some chronic asphyxia, meaning the placenta is not working right, the uterus is not working right, something between those connections, and the baby is not getting the oxygen it needs. If you see anything less than a 4, then we're going to strongly suspect that something's wrong and that brain did take a hit from the low amount of oxygen it has received. A contraction stress test is the next test that we can do with an abnormal non-stress test, and this really is like what's the right word? It's a practice run. It is a rehearsal to the real the real labor. So we're going to assess placental function and oxygenation, and how we're going to do it is we're going to put that mom into a simulated labor. We don't want to go into full-blown labor, but we want to see how that fetus reacts to the stress of labor. Remember, when the uterus contracts, cuts off the blood supply, is that baby able to recover after that contraction? So if they're not able to, then we will do a C-section, because we know that there will not be a good outcome during labor for that fetus. So the stress of that and seeing how well that baby recovers. We're going to do those monitors just like we did in the non-stress test, and like same as when the mom is in labor. We're going to take baseline again to see that fetal heart rate. And then we're going to put that uterus into some contractions. And we only want a few contractions. So we want to use a dilute or a small dose, a very light dose of oxytocin or nipple stimulation. And you can read about that on page 32 of your ATI in chapter 6. Those are the fetal well-being assessments. And once we get 3 palpable contractions with a nice duration within a 10-minute period, we know we can perform the contraction stress test, because we can see that uterus contracting nicely and see what that fetal heart rate does in response. So a negative contraction stress test is normal, meaning it's negative for no late decels. Remember, the late decels from lab is when the contraction happens, the baby can have a decel during that contraction, especially if it's ready to deliver and the head's right there being compressed and it's a vagling. But if it does that and then recovers once the contraction is over, we're not worried about that. But if the fetal heart rate stays down or below baseline and it takes a while for it to recover, then that's called a late decel. And if we do see late decels, or no late decels, then we know this is a normal contraction stress test and that baby will do okay with labor. If it is a positive contraction stress test, this means it's abnormal. It's positive for a late decelerations, meaning there is sufficient evidence of uteroplacental insufficiency. Okay, the next tests are some blood tests that we're going to do. The MAFPS, these are looking for these fetal serum proteins, the AFPs, and they're produced in the fetal liver. They can cross the placenta and go into the mom's bloodstream. So we're looking for the presence of those in adequate amounts. We do it at 16 to 18 weeks. It's every patient gets it. And we're looking for abnormalities. So if we see high levels of AFP, alpha-fetoprotein, then we know that there is evidence or risk. There's not a diagnosis. It's just saying we see that there may be a risk of neural tube defects. And I'll show you that on the next slide, what I mean by neural tube defects. These are the spina bifida, anencephalies, things like that. Or there could be a risk of abdominal wall defects. This is gastroschisis or omnicell, things like that, where the intestines are grown outside of the abdominal wall and the abdominal is not enclosed. The intestines are not enclosed within the abdomen, and the baby is born with the intestines outside of its body. That's gastroschisis. And then if you see low levels of AFP, this is a marker or a risk factor for chromosomal disorders, such as Down syndrome or a hypothyroidism, which I will explain what that is in the next week's lecture. So there are lots of false positives with this test. And so we run another test just to ensure our results. So these are the neural tube defects. You can see that you're going to have to go back yourself because I can't go back. Sorry. So if we see a maternal MSAFP that is abnormal, then we'll do a quad marker string, which is a much more reliable. I'm guessing it's more expensive because we only do it if we have to. It's done about the same time. It does not diagnose, just says the likelihood of fetal birth defects. And then we look for these 4 markers. That's why it's a quad marker. And if HCG is high, it's going to say something AFP, estriol inhibin A. All right, I'm going to pause right here because I'm almost at the 15-minute marker, and I'll finish with amniocentesis on the next presentation.